Okay, I think next I invite Humaira. Okay, Ophthalmology Emergency.
Okay, thank you, Doctor. I'll be presenting on eye emergency. Okay. 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 This is the anatomy of the eye. You can divide it into two, which is anterior and the posterior segment. In anterior segment, you can divide it into conjunctiva, cornea, anterior sclera, ecosuma, iris, lens, anterior and posterior chamber. In posterior segment, we have vitreous, retina, choroid, and posterior sclera, optic nerve. Okay, what we can examine in eye, the very common thing we can examine the externally lah. We can look for any asymmetry, proptosis, anophthalmos, or we can check for the orbital rim in trauma, and then check for the lids and duct. And then for the vision, we can check for the visual acuity using the Snellen chart, or if in worst vision, we can use counting finger or light perception. And then we can also check for the cranial nerve 2 until 7 lah, to check for pupil, visual field, extraocular muscles, and then facial droop. And then for papillary reaction, and then check for the tonometry. Tonometry, we check for the intraocular pressure lah. And then slit lamp to check for the anterior segment, and fundoscopy, the posterior segment. Okay, this is the gadget lah that we commonly used in optal, but I think we only have fundoscopy lah in green zone. Others we usually send to optal clinic for further assessment. Okay, first acute red eye lah. Okay, what usually patient we presented with is pain lah. Pain in eye often indicate more serious intraocular pathology. Usually can be iritis or glaucoma. And then patient can have discharge. If purulent, you can think about bacterial conjunctivitis. For visual acuity, if decreased, usually patient is more serious cause lah. And then for the pupil, if sluggish, we can worry about the acute glaucoma. And then also look for the pattern of the redness. If for the ciliary flush, usually the redness is worse near the cornea. And really serious intraocular causes is iritis or glaucoma lah. Okay, this is what usually we can ask is patient presented in with acute red eye. Like I explained before, ask for the pain, and then also we can ask for the whether patient wear contact lens or not, and then ask for other symptoms, as we want to exclude other differential diagnosis lah, and then ask for nausea, vomiting, abdominal pain, and then because this usually often signal for acute glaucoma. Okay, differential for acute red eye, it can be viral or bacterial conjunctivitis, foreign body, subconjunctival hemorrhage, angle closure glaucoma, iritis or keratitis. Okay. Doktor dah nak tambah apa kau untuk red eye?
Red eye. Okay, red eye, like we mentioned first, okay, patient come, the first question you ask is painful or painless. Kalau painless, macam tak banyak your differential. Okay, so kalau macam painful, then you see, is it trauma or non-trauma? Kan, kalau non-trauma because of infection lah. Kalau bukan infection, then you must think of glaucoma lah. Okay. So kalau glaucoma, usually patient come with headache kan. Headache, retroorbital pain, blurring of vision. Sometimes dia ada mid-dilated pupils. Okay, this is for glaucoma. Sebab kalau glaucoma is already an emergency lah. Okay.
Emergency.
Nanti you have to, okay, then okay, just now mention glaucoma. Okay, so apa yang common? Kalau kat ED kan, kalau you duduk green zone, what are the common red eye that you see? Sebab apa patient ada red eye?
Conjunctivitis.
Yeah, paling common is conjunctivitis. Okay, most conjunctivitis is viral lah. Sometimes it's bacterial. That's the most common. Conjunctivitis, paling common. Second maybe is foreign body, kan?
Foreign body.
Foreign body ada eye. Okay, foreign body ada eye. Itu. Then the other one yang quite common is photokeratitis. Photokeratitis. Sebab apa photokeratitis? Patient yang mana yang kita dapat photokeratitis? Patient yang welder. Dia buat welding tapi dia tak pakai protection. Dia tak pakai dia punya goggles. So dia akan datang dengan red eye. Okay. Okay, so let's say if you for examination this is in actually general we actually go back to your first few slides. Let's say you have a macam patient, how you want to assess the eye, all this daripada luar ke dalam. So always start with your inspection first. Kan? Always start with your inspection. Kalau trauma, you always comment patient ada periorbital trauma or not. Ada periorbital swelling. Maybe sometimes the swelling cause mechanical ptosis. Okay. Then after that you have to you examine daripada luar ke dalam. So apa dalam tu tengok, is there any foreign body? Is there any chemosis? So chemosis is conjunctiva. Then you see your pupils. So pupils ada banyak benda kita boleh assess kan. You want to know the shape. Shape tu round or not? Kalau trauma kita nak tahu, is the pupil shape dia normal? Is it round or not? Okay. Then after that you want to see the size of the pupils. Is the pupils reactive or not? Okay. After that baru you start your palpation. You can palpate. If kalau trauma case, you need to palpate around the whole eye. You look for any crepitus. Kalau ada crepitus, kita takut ada fracture of your sinuses, fracture of the bone. Look for any step deformity. Okay. Then after that, baru you ask patient to do dia punya movement. Check dia punya eye movement, extraocular eye movement. Tengok suruh dia tengok kiri, atas, bawah, kiri, kanan lah mata dia. Tengok. This is for trauma and trauma all the case. So you always start with your inspection first lah. Inspection daripada luar. Then you can comment semua sampai dalam. Okay. Fundoscopy I think you jarang guna kan? I think the one
kat green zone lah.
green zone so pakai fundoscopy. Most of the time your finding will be red reflex present or not. But quite difficult sebab kita dilate patient punya eye kan. Kan jarang kita dilate patient punya mata kan. So patient pun kalau dia datang sendiri, nanti if you dilate the eye, dia nak balik macam mana? Kan? Quite difficult lah. Okay. So then the other thing is for eye examination, if you want to, kalau patient tu dah sakit sangat mata dia pun tak nak buka, you can consider to give your Alkane. Your Alkane topical anesthetic at the eye. Once you give that, patient will feel comfortable, then you can examine the eye properly lah. Okay.
Okay.
So kalau patient tu dia punya mata berair sangat, dia gosok mata nak examine pun will be quite difficult.
Okay.
Okay lah, can continue. Okay. Painless visual loss.
Acute painless visual loss. Differential include cerebral vascular accident, central retinal artery occlusion, central retinal vein occlusion, wet macular degeneration, vitreous hemorrhage. Important history and physical finding have to determine whether it's monocular or binocular, and determine temporal sequence of the visual loss, whether it's intermittent, constant and unstable, or worsening. Okay. Then for close angle glaucoma, the pathophysiology because of the ciliary body normally produce aqueous humor which travel around the iris to be drained by canal scam. When iris block the canal, an acute increase in eye pressure leading to the rapid damage to the optic nerve and irreversible visual loss. Okay. Red eye with fixed mid-dilated pupil and hazy cornea, which are this usually presented in patient with close angle glaucoma lah. And then patient has extreme eye pain, and then the pressure usually very elevated lah, is more than 40. And then patient presented with nausea, vomiting, and abdominal pain, reduced visual acuity, often shallow anterior chamber, or narrow or close angle on slit lamp examination. This one usually optal punya finding lah, because you don't have the slit lamp in ED. And then the treatment is to lower the IOP lah. Usually we give acetazolamide 400 mg, timolol and pilocarpine drop 3 times over 15 minutes. And then we immediately refer to Optal.
Okay, this one memang kena refer. This is memang emergency lah. If you refer, they will see immediately lah, this one. Okay, glaucoma. So, kalau patient ada glaucoma, if let's say patient ada glaucoma, what are the medication that you need to avoid? Yang you tak boleh bagi kat patient? So, name me one common medication yang available in ED. Yang kalau patient ada glaucoma, you tak boleh bagi. Kalau you bagi glaucoma, dia lagi teruk. Okay, kalau patient ada glaucoma, then patient come with AGE. Kalau AGE with abdominal pain, what you normally give?
Kita bagi
AGE with abdominal pain. Patient come, diarrhea, then sakit perut. Normally you give what?
Yang
ni Amiza, tolong Amiza. Amiza, tolong yang
selalu bagi ORS ataupun abdominal pain, diarrhea.
Okay lah, you guys tak bagi Buscopan lah, bagi tak Buscopan?
Buscopan, ada bagi cukup.
So you must avoid Buscopan. Dia anticholinergic ah. So patient yang ada glaucoma, you cannot give Buscopan. You will worsen the glaucoma. Okay, contraindication lah. Okay. Okay lah, man. Boleh continue.
Okay. Next is detachment. This is because of the separation of the neurosensory layer of the retina from the underlying choroid and the retinal pigment epithelium. And then the risk factor for retinal detachment is due to the increasing of age, history of posterior vitreous detachment, myopia, trauma, diabetic retinopathy, family history of retinal detachment lah. And then patient we presented with complaint of black curtain coming down from the visual field, and then bright flashes of light, especially in patient with risk factor lah. The treatment is mainly surgical lah, this one.
So kalau patient kita suspect retinal detachment in ED, how do we confirm retinal detachment in ED? Macam mana? What's the easiest way to confirm? It will take you less than 1 minute.
History dia.
Examination. What you can do?
Examination.
What do you need to confirm RD? It will take you less than 1 minute, or maybe 30 seconds.
The patient cannot open their eyes.
Boleh. Usually it's painless. Okay, dia usually painless kan, retinal detachment. You can do ocular ultrasound. You scan the eye. You use your linear array probe. Nanti you can scan the eye. Nanti if you have a patient in NARSP, you can try to scan the eye. Nanti you can ask any of the MOs to show you lah. Where's the retina, macam mana? Where's the pupils? You can scan the eye actually. You can use your linear array probe. From there, kalau ada retinal detachment, it will be very obvious. Okay. You buat ocular ultrasound. Ocular ultrasound. Scan the eye. Okay.
Ocular ultrasound.
Okay, retinal detachment dia jarang lah happen like so suddenly. Dia usually is like patient akan ada progressive blurring of vision. Ni patient tak perasan, suddenly become worse. Usually yang the risk factor ni lah, like what you said, yang myopia, age, patient yang ada diabetes, hypertension, all these are risk factor to develop retinal detachment. So retinal detachment treatment memang surgery lah. And then not all centers can do retinal detachment is a subspecialty. Ophthalm punya subspecialty. Kalau nak repair your retina, not all ophthalmologists can do lah. Dia subspecialty. Okay, can continue lah.
Okay. Next one, foreign body lah. Foreign body, usually patient will presented complaining of foreign body sensation, patient with tearing, red eye and painful eye lah. And then we can check with stain with fluorescent stain and illuminate under blue fluorescent light to see whether the corneal epithelial defect lah. And then the management will be irrigation with normal saline to flush out the foreign body. If unable to flush by irrigation, probably the foreign body is embedded, and then we should refer to ophthalm.
Okay, so how you stain the eye tahu tak? You pernah buat tak?
Pernah itu dekat kulit prosedur.
Okay, so before you stain the eye, you have to do what? You kena bagi apa kat patient? Nah, before you stain the eye, kan you nak stain, you want to put the fluorescent stain, what must you put at the eye? You kena bagi your local anesthetic dulu kan, bagi alkane. Kan? You bagi alkane drops, give alkane drops, so mata dia tak rasa sakit, dia tak rasa apa-apa, baru you put your fluorescein. If you letak fluorescein macam tu, nanti dia akan pejam mata dia lah. Kan? Sebab reflex.
Betul.
Macam if you tak letak the local anesthetic, you don't give your alkane, it's like you're doing a corneal reflex. You letak the fluorescein patient akan pejam mata. So you need to put your alkane dulu. Before you do any procedure at the eye, before you nak buat even eye irrigation, give your alkane first. Give your alkane. Kira yang the special thing about eye is dia sangat senang untuk nak bagi LA. Your LA is your topical eye drops. Very easy. So you give, so patient tak rasa sakit, then you can examine properly. You can try to irrigate properly. You can buat staining betul-betul. Okay.
Okay.
So if you refer to ENT and they see a foreign body, kan? How they want to remove? How you think they want to remove the foreign body? Diorang guna apa? Tahu tak? What they use? They will use a needle jarum They will use the 25 gauge needle and try to remove the foreign body. Okay. No high tech punya equipment semua tak ada. Just use a very fine needle and just remove it lah. It will cause a bit of scarring lah, tapi normally the cornea will heal by itself lah. Okay. Okay, next.
Okay, and then the next one is orbital blowout fracture lah. This one consider when inferior orbital rim has palpable bony defect. So patient has diplopia, especially on outward punya gaze lah, and then decreased vision and history of trauma lah. Mechanism of outward diplopia is broken bone, cause direct entrapment of inferior rectus or edema, and inflammation leads to the functional entrapment of the inferior rectus. And then you can look in the picture lah. The arrow is showing the teardrop sign lah. This one show that patient have orbital blowout fracture. Usually, the management we can give ice pack at the beginning, and then for the first 48 hours, this will help lah to decrease the swelling associated with the injury. And then we can prop up the bed. If sinuses has been injured, we can give prophylactic antibiotic and instruct the patient not to blow the nose lah. And then we can treat the nausea vomiting using the antiemetic. And then after that, we can refer to ophthalm for further assessment.
So kalau orbital blowout fracture, okay, the most kalau your eye, yang paling weak part is the floor of the orbital rim. Floor lah, the inferior part lah. So kalau ada injury, usually tempat tu yang senang nak ada fracture. Sebab yang tu the most weakest part. Okay. So you must look for an entrapment. And then the treatment for our side nanti match lah. This one memang kena refer to ophthalm or maxillofacial. Then for our side, we just want to prevent patient from vomiting. Sebab kalau dia muntah, dia bersin ke apa, nanti it can make the condition worse lah. Worse. Worse. Okay. Okay, continue.
Okay, this is the picture. Okay, ruptured globe. Ruptured globe usually caused by the penetrating trauma lead to the corneal or scleral disruption and extravasation of the intraocular content. It can lead to the irreversible visual loss or endophthalmitis. which is inflammation of the intraocular cavities, like in the picture lah. Okay, sign and the symptom, usually patient will complain of pain, decreased vision, hyphema, loss of the anterior chamber, teardrop pupil, which point toward the laceration. This one we can check lah using the waktu kita buat physical examination tu kita boleh tengok dia punya bentuk lah. And then severe conjunctival hemorrhage, completely encircling the cornea. And then to diagnose, we can use Sider test. This one I think we don't have in our ED kot atau tak?
Sider test macam mana? What is Sider test?
Dia macam staining juga, tapi dia nak tengok aqueous punya leakage.
Okay, kita tak ada kat sini. We don't have.
Okay, the management, usually we immediately replace the eye shield to protect the eye from further manipulation, and then CT head or orbit to evaluate for concomitant facial or orbital injury, and then we can give IV antibiotic within 6 hours of injury. Can give cefazolin plus ciprofloxacin to provide good coverage, and then give tetanus prophylaxis, and then give antiemetic and analgesic to decrease the risk of salva or movement, which could increase the intraocular pressure. After that, we can refer to ophthalm for surgical management.
Okay.
Ya,
continue.
Okay, another one is retrobulbar hematoma lah. This one caused by trauma, surgery, or really spontaneous lah. They can lead to compartment syndrome of the orbit. And then we can suspect this retrobulbar hematoma if patient had complaint we suspect of trauma and pain, proptosis, decreased visual acuity, or increase in intraocular pressure lah. This one also nothing much we can do. We refer to ophthalm.
Okay, retrobulbar hematoma you can easily detect from the CT scan. Most of the cases that we see, patient mata dia tak macam ni, mata dia normal je. Tahu, cuma when you see the CT scan, you can see. You will see like there's blood behind the eye. So you must see your orbit, your mata. Then you must see your optic nerve. Only see your optic nerve. Then kat sebelah optic nerve, medial dengan lateral to optic nerve, in the CT you will see there's blood lah. So that's a hematoma. Yang tu you refer ophthalm lah. That one. Okay, continue.
Okay, and then corneal injury. Corneal injury, it can be abrasion or laceration lah. Okay, symptom patient will extremely eye pain, visual acuity usually decrease, depending of the location and injury relation to the visual axis. And also inflammation can lead to the corneal edema and can decrease the visual acuity. To diagnose, we can use fluorescent staining to see the epithelial defect and Sider test for aqueous leakage to diagnose the laceration. Okay, the Sider test just now yang tadi cakap tadi tu. And then for the ED management, we can give topical antibiotic and follow up with ophthalmologist lah. For laceration less than 1 cm, we give topical antibiotic and discharge. If more than 1 cm, can refer to ophthalm lah for further management. Okay. This is a picture of the corneal abrasion. Ini corneal laceration. Kita ada nak komen kau? Pasti ada?
Dah. Okay, continue. Proceed.
Okay. And then next one is the chemical burn. This is the true ocular emergency lah. Only ophthalmic presentation in which treatment should not be delayed to check the visual acuity. So the treatment is irrigate lah. So nothing much we can do. But we must irrigate when patient come with the chemical burn. If possible, we can irrigate up to 30 minutes using the IV bag with normal saline or lactate syringes connected to the irrigating lens placed on the eye, and then close eye after 5 minutes, and then we check back the pH with litmus paper in inferior conjunctival fornix, and then irrigate until neutral. The pH is neutral 7 to maintain for 30 minutes.
Okay,
Okay, before irrigation, give an anesthetic drop to improve the efficacy of the irrigation, and then also can sweep for knees to remove any remaining chemical debris. After irrigation, we can give the broad spectrum antibiotic, topical anesthetic, and tetanus prophylaxis lah. If conjunctiva and cornea appear white, it's a sign of severe burn. Chemical burn can be acid or alkali lah. Usually alkali will be worse compared to acid. Usually chemical burn caused by alkali we can find in household cleaner, fertilizer, and then if for acid we can find in like batteries and industrial cleaner. Belum sihat dah.
Tak ada. This one all the treatment for our side is irrigation. Irrigate lah. Irrigate banyak-banyak, then I just refer to optal lah. Tapi before irrigate, always letak your alkane lah.
Alkane.
Your topical LA.
Okay.
Okay, can continue with this one.
Okay. Then for central retinal artery occlusion, the pathophysiology is because of the emboli to central retinal artery leads to ocular stroke. The classic manifestation is extremely sudden, acute unilateral non-painful visual loss, and prior to history of emergency sphagex which is temporarily loss of vision. And then if we examine the eye, we can find that cherry red spot on the fundoscopic examination lah. Okay, and then the management, we must have a very high index of suspicion, especially in patient with appropriate risk factor lah. Risk factor usually patient with hypertension, age more than 70, dyslipidemia, diabetic. Okay, and then we can immediately refer to ophthalmologist. Because retina can be irreversibly damaged lah in 100 minutes. Okay, and then we can give mannitol or acetazolamide and to reduce the intraocular pressure. And then topical timolol also can be helpful lah. And then we can massage the orbit with finger. This is thought to help to dislodge the clot from a larger to a smaller artery branch. So we minimize the visual loss lah, because when they travel to smaller area. And then ophthalmologists usually may perform paracentesis or aqueous humor to reduce the intraocular pressure. Okay lah.
Okay. Ni semua rare lah. Your CRAO, CRPO semua you will rarely see lah. Jarang lah, tapi you need to recognize lah. All is very rare.
Okay, and then for orbital cellulitis, patient can come in with sudden onset of fever, proptosis, restricted eye movement, swelling, redness of the eyelids. And then in orbital infection can develop via to direct inoculation, extension from adjacent structure, hematogenous spread, preceptor space, particularly from the preceptor cellulitis in children. And then the skin. Okay, usually the management for preceptor cellulitis, if no sign of orbital involvement, for adult we can discharge, but for children usually we will admit lah for parenteral antibiotic. And then for orbital cellulitis, usually need for admission for antibiotic. For orbital abscess, we need surgery lah. This one refer to optal. I think
kalau
that's all.
preceptor cellulitis is more common than orbital cellulitis. Tapi you need to differentiate lah, sebab kalau preceptor cellulitis, then kita boleh discharge, tapi still need to refer to optal, tapi can refer as outpatient lah. Tapi kalau orbital cellulitis, we need to refer to optal, sebab memang kena admit, you need IV antibiotics. Preceptor still can treat as outpatient lah. So must need to differentiate lah between the both lah, preceptor dengan orbital cellulitis.
Orbital cellulitis.
These two. Okay.
I think that's all.
Okay. Okay, ada soalan tak? Tak ramai ni. Apa? Syami B, Lee, Anis, Vincent. Any question to your friend? Okay. Tak apa, next time boleh ask lah question.
Okay.
Ni, Humaira last day bila? Dah habis kan?
Last day hari ni tau.
Dia ni last day? Weh, hari ni? Then ada cuti lah, holiday lah. Yalah. Yang ke Amiza last day bila? Amiza
dah last dah malam.
Habis dah semalam. Oh, semalam. Okay lah. So sempat lah you guys present lah. Okay lah. So usually kalau CME, the one who benefit the most is the presenter lah. So you guys kena baca banyak. Okay. So thank you to both of you. Okay.
Terima kasih,
so
Doktor.
nanti floating kat mana?
Tak tahu lagi, Doktor.
Tak tahu lagi? Oh, dah last day pun tak tahu. Tak keluar list. Okay.
Sebab dia awal bulan.
Okay. Thank you.
Okay.
Thanks guys.
Okay, thank you,
Terima
Doktor.
kasih. Terima kasih, Doktor Rafeek. Terima kasih, Doktor Fairuz.
Okay, thank you.
Terima kasih, Doktor.
Thank you.